We can see it very clear.
Thank you. Can I go ahead?
Please go ahead.
Okay. Good afternoon, everyone. My name is Omega Chituo. I'm a public health specialist with CDC Zambia, and I'll be making this presentation with Dr. Paul Kamfer, a gynae oncologist at CDH, and he's also the Ministry of Health Cervical Cancer Coordinator. I have no conflicts of interest. So basically, I'd like to welcome everyone to today's meeting. We are just going to have a taste of what cervical cancer is all about. So we are basically giving an overview, and we hope to have further sessions where we will delve deeper, not necessarily on a Monday morning, but at other times, and that will be communicated to everybody. So the learning objectives for today are basically to understand what the current epidemiology of cervical cancer is today. We will also discuss prevention of cervical cancer and have a look at the different cervical cancer screening approaches that are taken in Zambia. And we will have a look at the different program considerations that apply to us. So basically, if you look at the slide here, you'll see that we have two maps on the left-hand side. One looks at the distribution of the cervical cancer prevalence globally, and you'll see that Africa is in dark blue, which is where we have a lot of cervical cancer cases. We have a few spotted in Asia and some in South America. The map below shows the HIV prevalence globally. And again, where it is dark blue, that is where the prevalence is high. And you can see from looking at these two maps that countries with the highest HIV prevalence have higher incidences of cervical cancer. Zambia, unfortunately, is the third highest when it comes to age standardized incidence rates in sub-Saharan Africa as well as globally. And if we look at the commonest cancers in Zambia, we notice that cervical cancer is the commonest at 22.9% of adult cancer cases. Annually, we have over 3,000 new cases and close to 2,000 deaths. We normally screen, we've screened about 3.1% of our population aged 18 to 69. And when we do screen, we find that about 10% of women have precancerous lesions.
So we'll move to our first poll question. Chatonda, we would like you to share it on our behalf because of the setup. Poll question: secondary cervical cancer prevention focuses on the following, except A, screening, B, treatment, C, vaccination. Secondary cervical cancer prevention focuses on the following, except screening, treatment, vaccination. We have 137 connection. I can confirm that we have voter apathy. Please let us turn up and vote. Secondary cervical cancer prevention focuses on the following except A, screening, B, treatment, C, vaccination. We welcome Lewanika General, Chilenje General Hospital. We welcome you. Okay, this is, we are going to end the poll and share the result. So, Dr. Chituo, I hope you can see that voting pattern so that even as you emphasize on what needs to be emphasized on. Thank you. You can go to the next slide.
Thank you. That was a very interesting, those were interesting results. I think close to 60% of people do know what secondary prevention is all about. Now, if you look at the graph on at the top of the page, you see it's a graph that shows prevalence on the y-axis and age in years on the x-axis, and this is for women. And this is showing the life course approach to cervical cancer interventions. You can see that HPV prevalence is highest in the youngest age group, and it wanes as one approaches 30 and reduces to a minimum level in 60. Precancers tend to start developing in the 20s, peaks after 30 years of age, and wanes in the 60s. Cancer tends to develop after 30. So to target these, we have interventions that target the different age groups. For those, for the teens, we use HPV vaccination, and that is known as primary prevention. And this targets mainly the girls 9 to 14 years, but it also uses targets boys, and that is where resources are available. HPV vaccination is given to both girls and boys. And we incorporate other health messages on tobacco, sex education, condom promotion and provision, and male circumcision. All of these are tailored according to the age of the child. Secondary prevention looks at screening and treatment. And this is targeted at older women. So we screen, we look for precancerous lesion. The ideal is to use a high performance test equivalent, better than HPV tests. And this is followed by immediate treatment of precancerous lesion. Tertiary prevention is basically treatment of precancerous as well as invasive cancer. So as a country, how are we faring in these different areas? We managed to have a round of vaccinations in 2018 and 2019, where we vaccinated over 252,000 girls. However, due to COVID and other priorities, we've not been able to vaccinate any more girls, but this is an element of the program that we hope will be scaled up once things have stabilized a little. Secondary prevention continues. We have over 70 districts that are able to offer screening and treatment. 45% of districts are able to offer LEAP, which is an advanced form of treatment for large lesions. And then we have piloted HPV DNA in Zambia. We did it in 2019, and we are currently scaling up, although slowly, the HPV DNA tests. We do offer tertiary prevention. We have CDH that has been seeing patients since 2006, and all our provincial hospitals offer general surgery and attend to gynae cases. The WHO is basically behind all this, and they have come up with a vision to build a world without cervical cancer. And the threshold is to have less than 4 cases of cervical cancer per 100,000 woman years. And all this to be done by 2030. How will this be done? By ensuring that 90% of girls are fully vaccinated with HPV by the age of 15 years. 70% of women are screened with an HPV test at 35 and 45 years of age, and 90% of women identified with a cervical cancer disease receive treatment, either for precancerous lesions or invasive cancer. And the aim is to have a 30% reduction in mortality. And the program tends to focus on women living with HIV. And why should we do that? The rationale is that on the left, you have the general population, HIV infected and HIV negative women. Now, what happens is HIV negative women tend to clear the HPV virus, which is a precursor to cervical cancer. However, the HPV virus tends to persist in HIV positive women, basically because of their immune system. And because of that, they are 5 to 6 times at more risk of developing cervical cancer. So basically, this graph is just giving us an overview of the number of women we have screened. Sorry about that. From September 2018 up to March 2020. Ideally, we're supposed to screen 100% of women living with HIV. Our HPV positivity, that is the number of women that we find with precancerous lesions, should be between 5 to 25% of the women that we screen. And our treatment goal is to have 90% of women identified with these lesions treated. As a country, we have over 600,000 women living with HIV, and out of those, 65% have been screened, close to almost 400,000. We have a positivity of about 7%, that is 7% have been found with precancerous lesions, and we have managed to treat 63%. We have quite a lot of work to do in this area, but the main reason we have done so badly is because of the few LEAP sites that we have within the country. But there are strategies that we have come up with where we can increase access to LEAP services. So where do we find these services offered? Unfortunately, health posts are unable to offer cervical cancer screening, and the best they can do is referral. Higher volume health facilities are able to offer screening as well as treatment and referral for more advanced lesions or cancers. All district hospitals with an operating theatre are able to offer screening and the full complement of treatment for precancerous lesions. Referral for invasive cervical cancer diagnosis and treatment is still needed. If we look at provincial centers, they're able to offer the full complement of services except for cancer treatment, and that is where CDH comes in. It was noted that women are being diagnosed with HIV and are being put on ART, but dying of a very preventable disease, and that is cervical cancer. So we need to put in a little bit more effort when it comes to screening, because we are losing lives needlessly. So within a facility, this is the cervical cancer screening client flow. How does a patient move from registry? And I just want to say that client flow depends on the location of the ART and the cervical cancer clinic. So this is an ideal client flow. It may differ depending on the location of the cervical cancer clinic. So ideally, a patient would come to the registry, go to triage, and if they're eligible, they'll be taken to the cervical cancer clinic where they're screened. After being screened, they are offered the relevant services that they came for. If a client is ineligible, they go straight to ART.
The second poll question: the following are risk factors for cervical cancer. Dr. Stewart, please give us the second slide. The following are risk factors for cervical cancer except A, high risk types HPV, B, multiparity, C, smoking, D, oral contraceptives, E, the diet. All the following are risk factors for cervical cancer except which one of these? A, high risk types of HPV, you know we have types of HPV. B, multiparity. C, smoking. D, oral contraceptives. E, diet. We'll run this for 1 minute. let's give our thoughts. The following are risk factors for cervical cancer, except, so all these are risk factors, but one is not a risk factor for cervical cancer. Which one is it? Is it A, high-risk types of human papillomavirus? Remember, there are types and grades. B, multiparity. C, smoking. D, oral contraceptives. E, diet. We'll end the poll and share the results. End the poll and share the results. Okay. Okay, that's Chatonda, right? Thanks, Chatonda. Okay, so
Okay.
Dr. Tuo, you can have a look.
Thank you very much. I can see it's quite interesting to see the responses. I guess we'll discuss them further at the end.
Yes, please.
Okay.
You can proceed the rest of.
Okay, thank you, Dr. Foloshi. Now, I would like us to go back to basics, and I know most of us deal with other areas other than the cervix, so it's always good to have a quick reminder of what we're dealing with. We all know that the cervix is a small fibromuscular hollow organ that links the uterine cavity to the vagina. And it consists of two types of cells. We have the squamous type of cells and the columnar type of cells, which are in the endocervix. And in the ectocervix, we have the squamous type of cells. And then we have an area known as the transformational zone, where the cells keep changing depending on the parity, depending on exposure to hormones and other such things. And this affects what happens whether or when they're precancerous lesions and how we treat them. So basically the cervix facilitates conception, it facilitates labor, and it protects the uterus from different infections. So how does cervical cancer I'm unable to see the top. So here, basically, we're looking at the lifespan of HPV. HPV peaks between the ages of 15 to 25, and particularly when there's early sexual debut, and there's chances of higher chances of developing cervical cancer because of the time that the HPV stays within the body. And the body may, if you follow the arrow, it may persist and you may get an HPV infected cervix. If you follow the arrow to the left, that the HPV is cleared. If the infection persists, you get progression, and that is around the ages of 25 to 35. And it may become precancerous lesions. However, there's still an opportunity, and it can regress and not develop precancerous lesions between the ages of 45 to 50, with persistent HPV infection and persistent precancerous lesions. It may develop into cervical cancer. And that is why within cervical cancer, we have an opportunity. The long latent period allows screening for us to detect cancer, precancerous lesions. So here are the risk factors that we looked at in the poll. In the beginning, this is again the progression from normal cervix to cancer, and whether there's clearance or regression or invasion. So the risk factors include age at first intercourse, the early intercourse at an early age is linked with cervical cancer, as well as multiple sexual partners and not using condoms. Long-term oral contraceptive use is also linked to cervical cancer, as well as smoking and multiparity beyond 7 children, and HPV genotypes. We have some that are high risk and tend to lead to precancerous lesions, whereas others are not so high risk. However, 99% of our cervical cancer cases are linked with the HPV infections. We've gone on to poll 3, Dr. Foloshi.
Our third poll question: what do these 4 pictures depict? So the pictures are in series. Let me just move that. Okay. So what do these pictures depict? Is it A, progression of a severe bacterial infection? B, progression of HPV infection? C, progression of cervical cancer? So you start off here, and then you can see an early lesion forming, and you can clearly see some redness and almost like a coating, a white coating. By the time you reach this, you actually see a fungating lesion on the cervix. What do these 4 pictures depict? Is it progression of a severe bacterial infection? Is it B, progression of HPV infection? C, progression of a cervical cancer? I must mention, this is a 2-part presentation. Dr. Paul Kamfwa, who's an OBGYN, will pick up at some point. He's also joining us for this session. So this is interesting. What do these 4 pictures depict? Is it A, progression of a severe bacterial infection? For those that may have joined us, so you start off with this almost very nice looking pink cervix, but you can see now that it's having some damage, some redness, and a bit of a discharge. Further on, it becomes quite hyperemic, and you can see some white coating over there. Then at the end of it, you end up with a fungating lesion, which is actually bleeding. So what is this? These pictures? Pictures matter in cervical cancer. We will end the poll and share the result. Dr. Chituo, that is the voting.
Thank you. I think I am talking to a crowd that has some experience with cervical cancer screening. So this is the last bit that I will look at. We'll look at the symptoms of cervical cancer. They may be asymptomatic and mainly because of the long latent period, or they may be symptomatic, and common presentations include discomfort or pain in the pelvis, in the legs, abdomen, back, or post-coital. The woman may also present with abnormal bleeding, including abnormal menstruation, or heavy or irregular menstruation, spotting, or post-coital bleeding. The woman may also present with abnormal vaginal discharge, typically, particularly in the later stages, foul smelling, or they may also just present with fatigue, nausea, or weight loss. And I think amongst HIV positive women, you need to be mindful because there's so many other things that can cause these symptoms.
Our 4th poll question, this presentation is rich in polls, so we are very happy about that. They are not very easy to make, but they're very nice polls. What proportion of affected lesions of the cervix determines the treatment modality? So I'm sure we also that picture. It's not uniform, right? So there are all sorts of patches there. So which one would determine what you treat? Okay, predominance. Is it 25%? Is it 50%? Is it 100%? Or is it 75%? What proportion of affected lesion of the cervix determines the treatment for the whole cervix? Right? It's not uniform. You see patches of early lesions, some precancerous, you may see some getting bleeding lesions. But what percentage says that, oh, we need to go for this treatment? So what proportion of affected lesion of the cervix determines the treatment modality? Is it A, 25%, B, 50%, C, 50%, D, 75%? We're going to end the poll in the interest of time, and we are going to share those results so that, okay, so there is a 25%, there's
Okay.
Yes.
Thank you very much. These are very interesting results, and I think we'll discuss the answers towards the end. So I'll stop sharing the results and hand over to Dr. Kamfwa now. Dr. Kamfwa, are you online?
Dr. Kamfwa? And Chatonda, may you please look for him? Maybe he's trying to unmute. Maybe he's trying to unmute. So as I mentioned, Dr. Kamfwa is an OBGYN. His strength is cervical cancer. They work very closely with Dr. Omega. Dr. Kamfwa? Okay, he's probably struggling with the connection. Please, all of us who have not put our names on the device, let us rename them. Let us give them the names. I cannot see Dr. Oh, he's struggling with connectivity. Oh, that's too bad. Dr. Omega, I guess it's on you to continue the presentation.
Okay, thank you, Dr. Foloshi. So basically, one of the approaches that we take with cervical cancer screening is known as visual inspection with acetic acid. And this is where we place 5% of acetic acid on the cervix for 5 minutes. As you can see, the picture on the top right shows vinegar bottles. That's basic household vinegar. And what happens is that when you place the vinegar on the cervix, if there are precancerous lesions, they turn white. And that is because of the large amounts of protein within the cells. So white areas are considered abnormal. If there are no abnormal cells, the cervix remains pink. And we also use a camera. We take digital images, and these are known as cervicograms or cervicography. And these pictures help us in making diagnosis and in ensuring where there is doubt, we can consult and somebody can support whatever diagnosis that has been made. So how do we determine eligibility for treatment? If the lesion covers less than 75% of the cervix, they're eligible for cryotherapy or thermocoagulation. If the lesion covers more than 75% of the cervix or goes into the endocervix, they're eligible for LEETS or LEAP. I will explain these terms as we go along. So the treatment for precancerous lesions is either through cryotherapy or thermocoagulation. This is Both of them are known as ablative therapies. Cryotherapy is when you freeze the cells, the precancerous cells, using carbon dioxide or nitrous oxide gas. Thermocoagulation is electricity which heats up and kills the precancerous cells. And the reason we use these treatment modalities are that they have a more than 90% cure rate. They're very safe, with less than one of them returning with the infection, and it has no effect on future fertility. It is highly acceptable to both the provider and also the clients, and it's low cost. And essentially, any nurses can do it, clinical officers, doctors. It's very easy to learn. And it enables us to link screening with treatment. So if a client is found with a lesion, they can be treated on the same day rather than being referred. And you can see the pictures on the left-hand side. There we have a thermoablator, then we have a picture of a cervix, and there's a nurse who's treating it. A nurse or doctor, she's female, so I can't tell. Then
Dr. Chituo?
Yes.
Dr. Kamfwa says he's back. Would you like him to pick up now?
Yes, he can take over. Thank you.
Thank you. Dr. Kamfwa? Dr. Paul Kamfwa? It looks like he's still struggling. I think you may just have to continue. He had typed in that he was back, but maybe he's still struggling. Please continue, Dr. Chituo.
Oh, good afternoon. I think I'm back. I'm so sorry. Connectivity was a problem, but thank you so much, Dr. Chituo, so far. I think we can move to the next slide.
Okay. She didn't really talk about this one.
So she was trying to talk about the ablative method. And in the ablative method, we have got cryotherapy and thermocoagulation. When you look at the lesion which has been projected, the lesion is eligible for cryo in that it is less than 75% and it is not going into the endocervical canal, meaning that this lesion can be ablated. Next slide. But when you look at ablative method, particularly thermoablation, sometimes thermoablation is described as cold coagulation. So what are the limitations? First of all, when we have got a big lesion, and what do we call a big lesion in cervical cancer or in pre-cervical cancer? It is a lesion which is more than 75%, or any lesion which is going into the endocervical canal. Reason being is that when you try to use the thermoablation, that cryo tip is not, first of all, going to cover the entire lesion. At the same time, it is not even going to go into the endocervical canal. So that makes it a limitation. Then the next thing is it needs skill and capacity. But the sad part is that when you have treated this patient with thermoablation, you do not know particularly what the patient has, such as CIN1, CIN2, or CIN3. Reason being is that it hasn't given you the histopathology. So that becomes one of the setbacks in as far as ablation is concerned. But one thing that you need to realize that women sometimes are going to experience mild to moderate cramping, but the adverse effects are not very, very minor, and it is just a matter of discomfort. But yes, next.
That you were waiting to see. Now you are seeing.
Next. So, when it comes to excision method, in the excision method, we either do lip or another method, which is cone biopsy. But in Zambia and in our program, the one that we do is lip. But the term which is nice to be used is LES. When you look at LEEP, the acronym stands for Loop Electrosurgical Excision Procedure, in the sense that we use a very thin wire which is heated with electricity, and we go on to excise that abnormal tissue of the cervix. But when you look at LES, LES stands for Large Loop Excision of the Transformation Zone. Dr. Chituo explained, and even in our program, especially for the subsequent echo that we shall be presenting, the most important thing that you are supposed to be doing is identification of the transformation zone. Reason being is that all cervical cancer begins from the transformation zone. And when you are doing VIA, when you are doing LEEP, you are supposed to identify the transformation zone. Especially the person who is going to do the LEEP has to remove the entire transformation zone, not just the acetoid lesion. Meaning that if we look at LEEP, it has got some challenges. What are the challenges? First of all, it requires more resources, such as specialized equipment and instruments and consumables. At the same time, it is technically more difficult, but you have to realize that it is a very safe and effective procedure as long as it is in skilled hands. Normally, what we want to say is that the LEEP is supposed to be performed in a facility where there is operating theater. Why operating theater? It's because sometimes the patient can have severe post-procedure bleeding, and this post-procedure bleeding can end up in taking the patient in theater. But in a situation where you do not have theater facilities, then that is going to be quite difficult. At the same time, the other challenge is that it requires anesthesia, and it is not available sometimes as a single visit approach. Next. So the question, Dr. Sombo will take that one.
Thank you so much, Dr. Kamfwa. The national VIA and HPV screening algorithm includes A, rescreening women living with HIV every 2 years. B, rescreening HIV uninfected women every 3 years. C, rescreening women post-treatment after 1 year. D, VIA should be done for every HPV positive woman. All the above is E. So we are gonna launch that from our end. Let's see what people think. It looks quite like a lot, but when you break it down, it's actually pretty clear. The National Visual Inspection and with acetic acid and human papillomavirus screening algorithm includes A, rescreening women living with HIV every 2 years, rescreening HIV uninfected women every 3 years. C, rescreening women post-treatment after 1 year. D, VIA should be done for every woman that is found to have HPV. E, all of the above. We have 235 connections. We have very poor voter turnout. Please, let's give our thoughts. The good news is in the subsequent slides, Dr. Kamfwa will actually go through all these and it will be clearer. So let's give it a go now. This is good voter turnout. The national VIA and HPV screening algorithm includes A, rescreening women living with HIV every 2 years. B, rescreening HIV uninfected women every 3 years. C, rescreening women post-treatment after 1 year. So these women have been treated for cervical cancer, then you have to screen them after a year. D, if you find a woman has HPV, all of them should undergo VIA. And E, all the above. We're going to end the polling and share the result. so that Dr. Kamfa can see how we voted. Oh, I may have clicked that too early. Okay, excellent.
Excellent vote turnout and excellent answers. Don't worry, you see the answer to come. We can go to the next slide so that we understand much more. So the way we have been doing, particularly with cervical cancer screening, this is the algorithm for VIA. Remember, we said that in VIA, it is a single visit approach. Why do we say it is a single visit approach? We want to minimize the number of patients with abnormal screening so that we do not have a lot of patients who are going to be lost to follow-up. So, in a situation where we have got VIA and in an HIV negative patient, then this patient will be rescreened after 3 years. In a situation where the VIA comes out positive, then we need to choose, should this patient go for cryotherapy or should this patient go for LEAP? Remember, the things that are going to guide us. Is the lesion more than 70% or less than 70%? Is it going into the os? Is it the mosaic pattern? Is it punctations? Those are what will guide us. If we do cryotherapy, the patient has to be seen after 1 year, and we shall do another VIA. If we do LEAP, a similar thing, the patient has to be seen after 1 year. So the take-home message from here is, when we are looking at a HIV negative woman and the VIA comes negative, let's rescreen that person after 3 years. But in a situation where there is acetoid lesion, whether it is going to be ablative or excision, we have to review this woman after 1 year. But in a situation where it is suspicious for cancer, we need to take a biopsy and that person should then be referred. Next. This is now for HIV positive. So again, for HIV positive, when we do VIA, it comes negative, but look at the rescreening. It has to be done 2 years. In the negative, we were saying 3 years. But again, for the lesion, it is going to be the same like the HIV negative. We have to assess, is this lesion eligible for ablation or for excision? And if we ablate or excise, this patient has to come after 1 year. And we do again VIA. If there is a suspicion for cancer, we do LEAP, and if there is a suspicion for cancer, we refer for diagnosis and treatment. Next slide. Now, this is what is going to be very important. Zambia is going to adopt a dual process of cervical cancer screening until all sites are able to perform HPV DNA RNA as the initial screening test. And remember, it has started like what Dr. Chituo said, pilot project was done, but we are going to roll it out throughout the country. So now, what is this algorithm telling us? I'll summarize it quickly. First of all, look at this. When a woman has done the HPV test, whether it is self-collection or either collected, and it comes out as positive, that HPV test is positive, the next thing that should be done is to perform VIA. That VIA, we are calling it VAT. That is visual assessment to treatment. So if then you do VIA and that VIA comes out negative, the woman should be rescreened after 1 year. if it is eligible for cryotherapy, the woman has to be rescreened, or the woman has to be followed up after 1 year. Not eligible, you do LEAP, and the woman has to be followed up 1 year. If it is suspicious for cancer, you refer. However, if the same HIV positive woman, you do the HPV and it is negative, there is that rescreen within 3 years. So when you look at that, how can we summarize it? So the quick summary for that is HIV positive, HPV negative, 3 years. HIV positive, HPV negative, 3 years. Then if it is HIV positive, HPV positive, then let's look at whether it is eligible for cryo or for LEAP, and we follow that. Next. How about in the HIV negative woman? So in the HIV negative woman, again, like what we said, this is going to be the initial test. We have done HPV, it has come out as positive. Whenever HPV comes out as positive, whether HIV negative or HIV positive, the next thing is to do VAT, visual assessment to treatment. Again, if we do VIA or VAT and it has come out as negative, we rescreen that woman after 1 year. If it is eligible for cryotherapy or we have to do LEAP, the follow-up will be for 1 year. If it is suspicious for cancer, we then refer. But of interest, because this woman is HIV negative, we are going to rescreen her within 5 years. Why do we want 5 years? And yet in the HIV positive, it was 3 years. It's because HPV negative women are at extremely low risk of developing cervical cancer in the 5 to 10 year period following negative tests. So the 5 years adds to the cost effectiveness of the program. So when you have got such a woman, how can we summarize it? The summary is HPV negative with HIV negative, 5 years. HPV negative with HIV negative, HPV negative with HPV positive, take the patient for VAT, and if negative, 1 year. That's it. Next slide. Now, there are those lesions which are going to come after you have done the VAT, and you find that the lesion is large. What do we do? That lesion then has to be excised and it should be using LEAP. However, when we have done speculum examination, just speculum examination, we see an ulcer, a lesion which is bleeding, which is irregular. Do not even waste time in trying to put vinegar on that. That patient requires biopsy. Do not LEAP. Once you LEAP the lesion, you are cutting into the progenitor cells and there will be proliferation. You know what is going to happen? The woman is going to say, I had a LEAP just a few months ago, but I've got this fulminant cervical cancer. It's because we had to cut through a lesion which was already the cancer. Next. So if you look at our program, the way it is, there are certain things that we have to look at, particularly the indicators. They are important indicators. Remember, like what Dr. Chituo said, we need first to look at treatment rate. What is this thing which is called treatment rate? In treatment rate, we look at the number and percentage of women who are either referred for LEAP or either referred for ablation and this complete treatment in a defined period. As a ministry, we have said the defined period is within 3 months, but we have been having treatment rates which are suboptimal. First of all, what should be the treatment rate? We expect it to be at least 90%, but where are we as a country? If you look at the provinces, the treatment rate is normally below 50%. Why? And yet we have got this national policy and there is a screen and treat. If you look at ablative method alone, the treatment rate can go to as far as 90% because our nurses, what they do is any woman that they see that she has got a lesion, and of course, if she consents saying my husband won't have a problem, I can be treated here and there will be abstinence, there is going to be treatment there and then. No wonder if you look at ablative method, the treatment rate is about 90%. But what brings it down to lower than 50%? It's the lip. If you look at lip, you are going to find that in facilities, there are women who are coming, going, you know, they have been told that the person who is supposed to conduct the lip hasn't been there. Of course, we know there are opportunities even as far as the treatment of invasive cervical cancer is concerned. Dr. Chito mentioned we have got CDH as long as a person presents even in the early stage, there is a window opportunity for cure of cervical cancer. Remember, it is not just preventable, it cannot just be eliminated, but there is even a chance of cure. So the challenges that we have is, even if we know lip is such an expensive thing, we need to scale up that. And we know we have got inadequate human resource and infrastructure, but what we require is to scale up this. And the other thing is that I know you who are in the provinces, you need referral feedback. And we haven't been doing this adequately. I think we shall discuss. The next step is you need to be doing a lot of outreach services. If you do a lot of outreach services, you are going to upscale your targets. So again, if you look at the human resource, we know that we need to train as many health workers as possible. And what we have been doing in as far as sleep is concerned, we are not interested just in gynecologists. We have extended it to the licentiates and even the clinical officers. So licentiates, clinical officers, and all the doctors in the provinces. And what we want to do to scale up that, we want pre-service training, even when people are doing fellowship, even when people at the clinical schools, clinical medicine schools, we want to start introducing this. Also, even those that are doing licentiate program, because this is the only way that we are going to be reaching as many women as possible. The next thing that we need to look at is the histopathology. We know where we seem to have a problem is the courier system. But this, most of the provinces, they have been leveraging on the courier system for what they do for viral loads. If we can leverage on that, it will be easier even for far-flung places to try to courier their specimen to Lusaka. But we know that the histotakes, of course, are a big challenge. We only have very few pathologists. The good news, especially for Western Province, I think as at now you have got a pathologist and most of your specimens are going to be, you are going to be receiving the results in good time. And again, let me just mention this. What has been happening at UTH is that, you know, they allocate your specimens to different registrars, meaning that the specimens which are coming from Southern Province, there's a particular registrar who looks after those specimens. And even if maybe there are those from Eastern Province, there is a particular registrar who has to take care of all that. So meaning that the next step is we need to set up more histopathology laboratories, and we shall do this in Livingstone, or all what we know is that sooner than later, I think somebody just has to clarify, digital microscopes has been procured if it hasn't been delivered. Next. So in terms of equipment, we know that LEAP equipment, it's available on the market. And the only challenge that we do have sometimes is limited resources. But we know as partners, there is a lot that is being done. And we know women who are living with HIV/AIDS, they are the ones who are at risk of progression to cervical cancer. And these are the ones that we want to prioritize. Then we come to the QA system. This is one of the most important things that is supposed to be done. I've appreciated with what you friends are doing in the provinces, especially reviewing the cervicograms, because that helps in as far as the QA is concerned. And this requires to be done periodically. We have seen that we have been having suboptimal implementation of that. However, we need to be having this. And the more we have this, the more we are going to know how we are faring. Not just on the pictures alone, sometimes, especially on the LEAPs that you have done, you need again to look at the QA. How many LEAPs that were done are incompletely excised? Because if you find that you are doing, say, 20 LEAPs and 15 or 10 are coming out as incompletely excised, remember, a LEAP which is incompletely excised is as good as no LEAP done. Another thing, when you haven't seen the transformation zone and you start reporting saying this is negative VIA, it's as good as VIA not done. On the M&E, we know we have got opportunities. We look at the data which have been included in the HIMS, and this is going to come next year. But the problem which we have, again, I go back to the core indicators. With regard to treatment indicators, there is need for us to disaggregate this core indicator to say, these are the patients who received ablative methods, and the percentage is this. These are the patients who received excision method, and the percentage is this. We shall then know saying it is the LEAP aspect which is pulling down the ablative method. Then the other thing that we have identified is poor documentation of referrals for LEAP, even the ICC. We need to improve on the documentation, and remember, we need also to scale up the smart cell. Next. Next slide. So, what have we learned today? If you look at where Dr. Chituo started from, we have said that when screening is done according to guidelines, cervical cancer is preventable. We know cervical cancer is preventable because we have got a window of opportunity. Reason being, it has got that natural history and it's long enough for us to do a lot of things. Not only do we want to prevent cervical cancer, but we want to eliminate. No wonder Dr. Chituo was talking about 90, 70, 90 strategy. And all of us, it's the song that we require to be singing, especially those of us who do the screening, the 90, 70, 90 strategy. Again, the next thing that we have learned is that women who are living with HIV/AIDS are 5 to 6 more times vulnerable in as far as cervical cancer is concerned because of their reduced immunity. The third thing that we have learned is that screening should be incorporated into routine HIV care. And the services need to be scaled up in order to improve the access. Last thing is quality assurance activities are needed to review images on site key to maintaining quality of diagnosis. So meaning that if they tell you that your facility is the one that is going to help us look at the images, please avail yourselves, because that is the only way where we are going to be benchmarking ourselves and to know saying we are doing the rightful thing. So we are going to go back. First of all, those are the acknowledgements, Ministry of Health, PEPFAR team, the implementing partners, and also references on individual slides. The email shown is for Dr. Omega and Kamfwa. So Dr. Omega or Dr. Sombo are now going to take you back to those questions that they had given you to see the answers that you gave. Thank you so much. Dr. Omega or Dr. Sombo, you can take them through.
Thank you, Dr. Kamfwa. The poll question number 1, secondary cervical cancer prevention focuses on the following except. So secondary cervical cancer prevention does focus on screening and treatment. Vaccination is primary prevention. And I think quite a number of people got that one correct. The poll question, the second poll question, the following are risk factors for cervical cancer except A, HPV risk type, high risk type HPV, multiparity, smoking, oral contraceptives. Diet is not a risk factor. The others are risk factor for developing precancerous lesions. And I think quite a number of people, over 80%, got this one correct. The third poll question looks at what do these 4 pictures depict. And I like the way Dr. Foloshi described each picture. You could see the progression. And this one is very easy to confuse. It could be a severe bacterial infection, progression, but this one shows progression of HPV infection. And the last picture shows a severe HPV infection, which could then progress to cervical cancer. So for those of you who answered C, you were not too far off. You did quite well, but the correct answer is B. For question 4, what proportion of lesions visible determines the treatment modality? And I think Dr. Kamfwa stressed on this one quite a bit. 75% of an infected lesion will determine whether we treat it either using LEAP or cryotherapy or thermal ablation. So if it is less than 75%, we can treat it immediately using cryotherapy or thermal ablation. If it is larger than that, we treat using LEAP. Poll question 5, the National VIA and HPV screening algorithm includes rescreening women living for HIV every 2 years, that is correct. Rescreening HIV uninfected women every 3 years, that is correct. Rescreening women post-treatment after 1 year, and VIA should be done for every HPV positive woman. So all these are correct. Dr. Foloshi, over to you. Can I stop sharing the screen? I can't see Dr. Foloshi. Is the Western Province team ready to present, and are you ready to share your screen?
Okay, thank you so much, Dr. Chituo, for that. We lost internet, came back, and we lost host. So you did a great job. Please, Western Province, you can share your screen, but as they are sharing, are there any questions from the network? That was a great presentation, Dr. Kamfwa and Dr. Chituo. We learned so much. We're discussing with Dr. Kozia when we lost internet. Please, Western, prepare to share your screen as we take a few questions for our experts. Is there any question? Katanga Kalunga, please go ahead with your question. Please, let's unmute him.
Just unmute.
Katanga, please unmute your microphone and ask a question. Do we have anything in the chats? Any questions? Okay, you are having a lot of, okay, there's something in the chat, but what we are finding in the chat is a lot of, thank you so much for your presentation. It's very well explained, but there's one comment that just says from Lillian, she says, it is true, QA on reviewing of pictures is cardinal. Just remind each other on what is right. And some types of infection may compromise on making a diagnosis. I think Lillian here has produced a pearl, because we don't want to miss cervical cancer, of course, because you're only going to check it out 3 years later, and that really, really compromises a patient, because that's 3 years of something maybe progressing that you may have misread. So the program to read cervicograms will be very cardinal, so that we are continually reminding each other of the abnormalities of the cervix. Dr. Kamfwa, I have something to say before Western. Mr. Kamfwa?
Yes, I had a question here. I was looking
please.
at the steps which were shared regarding the HR aspect. On the pre-service training, I'm not sure when we're likely to start this, because there was no duration or a period of implementation of the same, looking at the issue we're dealing with. Thank you.
That's a very good question. So pre-service training, when are we likely to start, Dr. Chituo? In terms of human resource for health, when are we likely to start pre-service training?
Thank you for that question. That is an area that is being explored. Unfortunately, a lot of the programs are bombarding the students. And so we are still in discussion with the schools, the nursing schools, the clinic officer schools, as well as the medical schools. So I really can't give it a definite timeline for now, but those discussions are ongoing. Thank you.
Much for that. Jones and Jasper, please go ahead. I see Julie's hand is up. Please just type in the chat box. We have run out of time because of the internet. Julie, you can type in the chat box. Jones and Jasper, we see you very well. Your slides are very clear.
Okay. Thank you. Good afternoon, everybody.
Good afternoon.
My name is Kaya Jasper. We are to provide the consumer, as you can see from the presentation.
You can go ahead. You can go to the next slide, Jones. Are we struggling with the slides?
Okay. This is Mrs. NMU, female 29, was initiated on ART in 2015 at Sioma Rural Center. Since initiation on ART, her viral load has been above 1,000 copies per minute, despite enhanced adherence counseling. In 2017 wireless on EAC, she presented with anemia, hypothermia, and hypotension, and she was put on HEMAP and other drugs. Visual inspection with acetic acid was done, and it was negative. In 2019, she decided to stop taking ARVs due to the weakness she attributed to the drugs. In August 2019, she presented with low abdominal pain and declined cervical cancer screening services. She was recommended on tenofovir, lamivudine, and efavirenz. However, in May 2021, the client came with severe abdominal pain and accepted cervical cancer screening. The screening was done with visible cervical ulcers and BAPS results not yet received. OBS and gyne history, there was para4, no history of fistula or edema. The LMP was irregular menses lasting for a week, sometimes for 2 weeks. Socioeconomic history, the client is a housewife. Index conducted and listed 3 sexual partners. 1 husband was negative, commenced on PrEP. 2 KPs who live within Sioma. Physical examination, the vitals done on 9 May 2021, temperature was 35.9, weight was 50 kg, BP was 85/56, pulse was 102. General condition, generally weak. On general examination, a febrile to touch, no pallor, jaundice, and edema. No lymphadenopathy. The CNS was normal, the RS was clear, CVS sound was 1 and 2, better than normal. Per abdomen, mild tenderness on palpation of the lower abdominal region. Specular examination, visible cervical ulcers with easy bleeding. That's the picture for the examination. It was taken. Then on clinical timeline, on the 23rd August 2017, the viral load copies were 1,127, and the client was on tenofovir, lamivudine, and efavirenz. On 15th December 2018, the gene expert for sputum was negative. Then the HB was 7.4. RPR was NR. The viral load was 29,997. On 27th, on 14th August 2020, we started our grant on tenofovir, lamivudine, and efavirenz. On 27th January 2021, CD4 count was 368. Proteins were trace. HB was 10.5, RPR, NR, and the viral load was 9,543, still on tenofovir, lamivudine, and efavirenz. On 25 February 2021, cervical cancer screening, there was invasive cervical cancer suspect. Then the viral load, still waiting for the results, while the patient is still on tenofovir, lamivudine, and efavirenz. Our questions now. What is the normal turnaround time for BIOSP results? And how can results be tracked? Question 2. What is the best ART regime for the client? Question 3. How do we manage women living with HIV who decline cervical cancer screening services? That's the end of our presentation.
Thank you very much, Jones. So the presentation from Sioma is a very good presentation. You could even see they had the picture of the cervix. Maybe you can just show us that picture again. So essentially, this woman is only 29 years old. Okay, she's been in care for some time. She's HIV positive on ART Unfortunately, we saw a pattern of persistently elevated HIV viral loads. So of note is that there's a history of default early on in 2019, restarted in 2020 on TLE, seems to have presented in 2017 with anemia, hypotension, and hypothermia. At the same time, she had a VIA that was negative. She did come back in 2019 and was offered the test because remember it's 2 years in HIV positive. She declined it, but did have some symptoms that were concerning, like low abdominal pain. In 2021, she presented again, of course, to care because remember she was re-engaged in 2020. Unfortunately, her speculum exams are as shown in the picture there. You can see some whiteness and bleeding. They did a biopsy. Of course, they were concerned about invasive cervical cancer. So this is the lady, female 29, high viral load on TLE with a very suspicious cervix. There's a question, any questions for the presenters before we go to our expert panel?
But my apology, right. I was being right. Yes. Where? That's one.
Any questions? Okay, we'll go straight into the, I think there was a question, I saw a comment in the chat box for the team. I feel the client is failing ART. If she's adhering, why can't we switch to second line? I think that is their question as well on too. So Pomwale, thank you very much. What second line? And they're asking, was the client enrolled in enhanced adherence counseling? Jones, did you enroll this client in enhanced adherence counseling?
Yes, please. We did that.
I saw that as well. So well done. There's a question in the chat. I don't know who that is. I can't. So Muguyeta, please, we need someone to read the line. Do we have statistics on quality assurance on screening for VIA and LEAP services? Are the provider skills dropping, maintained or improved annually, and can the program determine with training needs? Okay, so this one is on training. So Dr. Kamfo, is it?
No, he's struggling with internet. So
Okay.
it says you try and connect.
Again, because he's supposed to help us about with number one, which talks about turnaround time. They did this biopsy more than 3 weeks ago, I believe, in February. Kwegi, are you, I see Dr. Kwegi is there. Are you able to assist us? What are the expected turnaround times? This biopsy was done in February and we're in June. What should we expect in terms of when we do a biopsy? What's the turnaround time? And how do we track this biopsy?
Yeah, there's one thing that I've noticed that of late, the turnaround time has reduced to less than 1 month. So it depends. There's one advice that I'm going to give you. You need to check with your lab as the sample been sent to UTH. Sometimes you might find that the sample is due in Western Province, but once the sample reaches UTH, the turnaround time is less than 1 month. I think I've had a chat with Dr. Moore. Like for us at Choma General Hospital, all the samples that we send, usually we get results within 1 month. The only problem that we have is that UTH does not spontaneously send the results, but you have to make a follow-up. So you have to make a follow-up. You find that the results are there if you took the sample to UTH in February. That's my comment, Dr.
Thank you very much, Dr. Kwegi. So it looks like we may even have a bit of provincial variation, but with great improvement. So some people are getting their results back as early as 1 month. I see Albert Chama, please go ahead with your answer.
Actually, it's just a question or looking at the turnaround time for the results. And if we are saying that this is an invasive cancer, we really help the patient for clinicians to be able to make a decision on that patient faster so that the patient is helped. Because if the turnaround time does not favor the patient, it means treatment will be delayed. And once treatment is delayed and it's an invasive cancer, it will really compromise the treatment outcome of a particular patient. Thank you.
Thanks, Albert. I guess the temptation is to treat because it looks like cervical cancer. But I know working from CDH that you really cannot treat cancer until you have a biopsy diagnosis. You need to remember that this differential may be wider than it looks. It may just be an aggressive infection. And we've seen things like schistosomiasis of the cervix. And you can imagine if we subjected schistosomiasis of the cervix to chemotherapy from CDH. So for sure, we need very good turnaround time, but you are not allowed to treat CS cervix presumptively. I know the delay is inconveniencing, but it's not part of the Zambian guideline. And as Dr. Kwegi said, he said that you need to have very strong linkages with your lab and main UTH if it's coming this far. So people are asking for contact for to the lab as usual. I don't know if Dr. Shu can help us. There's a lot of questions. Mpanje Sinkala, there's a lot of good questions there.
Dr.
Yes, good afternoon, Doc.
What was the question? Sorry. Okay, over to the person with the raised hand.
Yes, Doc. The question concerning switching the client to second line, I don't think it has been answered since the clinical mentor said the client was enrolled in enhanced adherence counseling and the client is adhering to treatment. Why don't we switch it to second line? Thank you.
Okay, so thank you. You have actually ushered us into the second line. What second line would we like to recommend for this individual? I don't know if there are any volunteers. Rose Chira, do you want to pick this one up? I know there's Dr. Bosco says we need to switch to second line, but you need to make sure that you've explored the barriers to adherence, find the strategies to overcome this adherence. You can only switch to second line when you've overcome these. Of course, we have to acknowledge she's on TLE, and this is a reactivated TLE. So her risk of failure is obviously higher than somebody who's naive to TLE. So we need to do the counseling. But what second line would we use? Any suggestions? Any volunteers? Rose Chira? Any suggestions of possible second lines for this woman? If we do all the counseling and she says she's ready and we feel she needs to go to a second line. Okay, so Luamba Mtendere, I like that. He proposes that we use AZT3TC with dolutegravir. Any other suggestions, or we are all comfortable with this? Somebody is saying they would go with AZT3TC and lopinivir. I think I'll address this question in the interest of time because our second line, we actually encourage dolutegravir. So AZT3TC dolutegravir would be a very good one. Of course, you can also use AZT3TC lopinivir if you have a contraindication. However, we always have to remember pill burden, and the only risk you are carrying with using AZT here is if this is cervical cancer, she's going to progress in terms of her anemia. You will note that her HB dropped from 7 to an 8. It's at 10, which is okay. But once it drops to less than 8, you may have to compromise your AZT. You can use something like atazanavir with dolutegravir. So somebody, Mercy, is saying that for question 3, we should do education and counseling because most of the women with HIV, living with HIV in villages have a lot of myths with the speculum. And for us, they've made it a mandate for women who come for ART that they should be screened before they actually collect their medications. So they are following the algorithm that we were shown. There's a lot of comments. There's one question, I think if Dr. Kamfo or Dr. Chituo can pick it up. The question was from Dr. Mubiana. I don't know if Dr. Mubiana would like to unmute herself. However, her question was, if you see a lady and you saw, okay, Dr. Koze, do you want to pick it up? Where after 2 years they saw a cervical in situ or something. There was a question on it. Please, Rhoda.
My question was,
yes.
I think the VIA screen was negative for this woman. And 2 years later, it looks like, although we don't have the confirmation, it looks like she has an invasive lesion. And Jane has responded saying it's possible. I thought maybe at least VIA should have shown something, not completely negative.
Okay, so thank you so much. Dr. Mangala is asking, you come for a VIA, you're told it's negative. 2 years later, you're being told you have something quite advanced on your cervix. Is this something we should expect or question? Dr. Kwegi, are you able to guide us on that?
Which one? On the case itself, or was that the comment on the VIA that was done on this case?
Please go ahead with your comment.
Yeah. I followed the case presentation, and the VIA findings were that, speaking of examination findings, were that she had some ulcerations of the cervix, and then they proceeded to do LEEP. To me, that same time she already had invasive cancer. What she needed was a biopsy. So 2 years later, I'm not surprised.
I think I thought she was negative. Thank you.
Pardon?
Sorry, I think I missed that. I thought she was negative VIA screen.
No. The first time she accepted to have VIA done on her, she had the ulcerations on the cervix, and they did a LEEP. That treatment was inappropriate. What this client required was a biopsy right from the beginning. Yeah, those are the comments I wanted to make on this particular case that was presented. But concerning Dr. question, I'm not clear about it.
Okay, I think I can see where we kind of got mixed up. I'm going back on the slides. I don't know if Jones, you can go back. So in 2017,
yes, please.
2017 is actually negative. So there was nothing. Then in 2021, that's when they had the ulcers and the bleed that they biopsied. So Dr. Craig is saying if they had seen something, they should have done a biopsy then, but they actually didn't. But the timelines are, it's 2017, they saw nothing. 2019, she declined. Then by 2020, it had now, this is the picture we are seeing, something quite advanced. That's like 3 years. Okay.
And Dr. Fellowship, and the LEEP was done. So the treatment wasn't appropriate.
Oh, they didn't.
What she needed was a biopsy. Remember what Dr. Comfort was talking about when you do a LEEP on invasive cancer. You actually make the progression of the cancer much faster. Thank you.
Okay, now, this is actually a very important observation, because even when Dr. Kamfwa presented, when you see something that's abnormal that should not get a LEEP, it should not be LEEPed, so that you collect the biopsy. Because when you are doing a LEEP, you are now invading into the blood vessels and you can make it progress. So that's a very, very, I hope we've all observed this, that this treatment management was actually not correct. Because if you suspect it's a cancer, you need to send that for biopsy. Thank you so much, Dr. Kwegi. How was the TZ at first? I don't know what TZ is. Okay. So maybe moving on to the, I think we've been told about the turnaround times that you need to link up with UTH, and you need to do for now, in terms of tracking, you have to be quite proactive. You can't sit and wait, because it may actually be ready in the lab. In terms of regimes, you've got a spectrum. There is one that you can use AZT, 3TC, dolutegravir, preferably because anemia is not bad, but you need to watch it very closely. It may drop any time. It's very friendly because your pill burden won't be high. However, if you do get an anemia in this patient that you are looking for, you may have to drop that AZT and replace it with an atazanavir. I know I saw a question like that. So you can give atazanavir with dolutegravir. AZT, 3TC, lopinavir is also an alternative. Dr. Chitua, would you like to zero in on number 3? When women refuse services like this woman, she did have an opportunity to get this picked early. She refused. What do you think they should have done? How do we treat women who say, I do not want a speculum in my cervix? Any ideas?
Thank you, Dr. Thank you, Dr. Foloshi. When we encounter such clients, basically what we need to do is, if I counsel a client and she declines, we have that woman in the facility. Let's make use of that opportunity and maybe try and bring on board somebody else who could try to persuade her to be screened. If she refuses, we could continue following her up at every opportunity that we have whenever she has a visit to the clinic, whether to collect drugs or to come back for viral load, would make use of that opportunity to continue counseling the client. Apart from that, we need to be mindful of what is going on in our communities. Do our communities understand why we advocate for cervical cancer screening? And apart from following up to find out whether our communities understand, we must also get feedback from them as to whether they have received the correct message. You may send a message out there and it may be misinterpreted. I don't know if any of you have heard of that game where you whisper in one person's ear, and by the time it gets to the fourth person's ear, the message is completely different. So we need to be mindful about what is circulating in our communities about our health programs and be ready to correct them. So for such a client, that's what I would advise. Thank you. I hope that's helpful. Over.
That's actually quite clear, but Dr. Kozia had something to add to this, a very interesting observation.
Yes, thank you so much, Dr. Omega. In addition to what you've said in the community, even facility environment is very critical at this particular time. Sometimes you may find that there may be the workers, the staff around there maybe are within for the neighborhood, and the client just doesn't want to be known by the staff around there, the community-based volunteers around there. So maybe also we really need to check ourselves as an environment where we are offering, who's offering the counseling services, who's actually talking to the client. Sometimes that may also discourage them from declining the service. So that's also another important aspect to keep in mind. Thank you.
Thank you so much, Dr. Because they're extremely important, because it's, I know, let's say it is maybe not a sexual organ, but it may be related to sexuality. Yes. So it's a sensitive topic. And the Wanika General has reminded us it's very important that these services are offered side by side. We saw the data there, it's very grim. Women with HIV are 6 to 8 times more likely to progress. And this is a disease you can prevent 100%. So ideally, no one should be dying from cervical cancer because we do have the tools. I think there was a question on the transformation zone, but I've been distracted. Jones, do you have any questions? We've been educated about how we can improve our turnaround times and how we can track our samples. Let us remember that the ministry is working very hard to improve this. There are pathologists in most parts of Zambia now. You could hear Southern Province has a turnaround time of less than 1 month, something that we even had issues at UTH, but if Southern Province is able to do that. So we need to engage our lab, make sure the sample has gone. Let us not wait for the result. Let's be proactive. We can phone UTH. I know there was a contact that was asked for I don't know, Dr. Chituo, if it's okay if we can share maybe Dr. Kamkwa's contact, then he can link the various provinces to the lab services in terms of histopathology. Is that okay, Dr. Chituo? Maybe it can be typed in the chat box. And then in terms of regimen, AZT3 dolutegravir would be appropriate. Likely she's failing, okay? Remember, she's TLE exposed, but she's at risk of anemia, but there are good alternatives to that, like atazanavir. And we talked about counseling and being sensitive to environment and our culture. Jones, any last words? Jones, any last words on this case?
No, we really appreciate all the comments. We've taken note of all the comments that has been given to us. And yeah, we really need to work forward the issue of cervical cancer sensitization so that we can prevent these cases from happening in the future.
Thank you so much. So Dr. Omega, Dr. Kamkwa, thank you very much. And Dr. Kwegi, thank you for that observation that they did a leap on a lesion that should not have had a leap in the first place. But it's a learning process. These slides will be shared and the contacts will be available, so we can get in touch with Dr. Kamkwa. He may be able to even help us track this sample, because this woman is actually, she's at risk of actually serious progression if indeed this is cervical cancer. We will meet, not next week Monday, because I've been told it's a holiday, but another Monday, and we'll be discussing on ART optimization in the pediatric population. Thank you very much, and enjoy the rest of your day.